Good morning all. May I request now Professor S.P. Dhaneria sir, Professor Chayna Sarkar madam to please kindly chair the session. Yes, I know. Achha, theek hai. So may I request madam to chair the session. So it is our real honor to have madam with us, Professor Chayna Sarkar. Madam is currently head at Department of Pharmacology at Negrims, Shillong. Madam had done her DM in clinical pharmacology from PGI Chandigarh. So welcome madam. Now please moderate this session.
Good morning everybody. So today's session is the smart use of antibiotics. We'll start now. So you know already the extravagant use of antibiotics has resulted in rise in multi-drug resistant bacteria. Therefore, it is essential to use antibiotics in an optimal manner to prevent the antimicrobial resistance. And already you know that WHO have started 2019 classification of antibiotics on the basis of that AWAR classification, mainly based on how much consumption of antibiotics in various categories, like access group or watch group of antibiotics or restricted use of antibiotics. So, to this session, we have three speakers. So, first, all are related to this, how to use, better use, optimal use, appropriate use of antibiotics that will present. So, now, I would now request Dr. Bhaskar Krishnamurthy. He is going to kindly deliver his speech entitled on antibiotic prescribing in critical care. So, Dr. Bhaskar Krishnamurthy, please.
Thank you, madam. Very good morning to my respected seniors, my dear colleagues, and everyone attending. Am I audible? The screen is clearly visible? All good? Okay. So at the outset, I would like to thank the organizers for giving me an opportunity to speak on this stage, and more importantly for having my session in the early morning, because a few years ago I had come across a survey which said that the number of people likely to sleep in the lecture is least in the early morning session. Noteworthy point, they said least, they did not say zero. So the topic allotted to me is antibiotic prescribing in critical care. To be very honest, it's a topic for an entire conference itself, but I'll try to summarize this in the allotted time by giving an introduction of the topic. What are the PK/PD changes that occur in the critically ill and how do they occur, with a few examples. Certain recommendations which are there in the literature with some way forward, and I'll summarize my presentation. So to begin with, infections are extremely common in the ICU setting. In fact, in a majority of these cases, the infection may be the cause of ICU admission. There is sepsis, septicemia are commonly seen. If it is a hospital-acquired infection, it is more likely to be an antimicrobial resistant pathogen. There are MDR, multi-drug resistant pathogens, which are now known to cause infections. And studies have reported that the per capita antimicrobial consumption is the highest in the critically ill population. And if the antimicrobial use is not appropriately designed, if it is unnecessary or if it is prolonged, then it can lead to various harms, such as increase in the hospital stay, increase in the cost of therapy, including increase in mortality. So that is why this is a special population we need to consider while designing the antimicrobial use. So what are the various factors which affect the PK/PD of drugs in the critically ill? The pathophysiology of the disease itself can affect the drug PK/PD. Generally, in the ICU patients or the critically ill patients are likely to have multi-organ failure. Liver and renal failure can affect drug clearances. The organ support therapies that we use, like renal replacement therapies, mechanical ventilation, extracorporeal membrane oxygenation, they can also have an effect on the PK/PD of drugs. And needless to say, polypharmacy is extremely common in this population, and that can lead to a high incidence of drug-drug interactions. So, the various PK/PD changes that occur in the critically ill, the volume of distribution increases, more so for the hydrophilic drugs. There are various reasons for this. There is inflammation in these patients which cause vasodilation, increased capillary permeability. It can lead to edema and loss of drug into the interstitial spaces. There can be reduction in serum albumin secondary to liver dysfunction, which can increase the free form of drugs. There are body weight alterations which occur. Even intensive care procedures have an effect on the drug PK/PD. So all of them combine to have a increase in the volume of distribution. Even the external fluid support that we give can lead to increase in the blood volume and dilution. So the volume of distribution can increase. The clearance can either increase or decrease depending on the situation. Renal failure can decrease drug clearance. If the patient is undergoing renal replacement therapies, the drug can be excreted by hemodialysis, so clearance would increase in such a case. Plasma protein binding changes, and not only PK but even the PD part is affected, because the MIC or the minimal inhibitory concentration that we calculate, it is generally based on in vitro studies where we have a static concentration of the antimicrobial and a fixed microbial load. Generally in the in vitro studies we have a 10 raised to 6 to 10 raised to 8 colony forming units per ml of the bacteria or the microbe. But in a setting of sepsis, there is a possibility of high microbial load. It may go up to 10 raised to 10 to 10 raised to 12 CFU per ml. So the actual concentration or the actual level of the antimicrobial that we have may be insufficient to take care of this high bacterial load. At the same time, if it is a resistant pathogen, naturally the MIC is likely to be higher. So both PK and PD are affected in the critically ill population. Various studies have shown various examples where the absorption of the drugs can be reduced if there is a increase in the gastric pH or decreased perfusion to the GIT or reduced intestinal motility or reduced apical drug transporters due to loss or disruption of the architecture of the colon. The distribution of the drugs can be affected because of hypoperfusion, hypovolemia, decreased blood flow to various organs. There are fluid shifts also. In yesterday's presentation, Dr. Sumit Matthew had said loss of drug into the third spaces, loss of drug into ascitic fluid, and then when the ascites is drained, the drug is lost along with it. Same thing can happen with pleural effusions also. So third space losses of drugs. Then variations in albumin and alpha-1 acid-glycoprotein can affect the free form of bound drugs. The hepatic enzyme activity can be affected primarily due to a hepatic disorder or secondarily due to increased toxins in case of renal failure secondary to uremia. There can be acute kidney injury or the renal failure can occur, and renal replacement therapy itself can have variable effect. So coming to hemodialysis, the dialysis membrane, the dialysis machine or the membrane itself acts as an organ of excretion. Multiple factors affect the clearance of drugs, which can be classified into drug, dialysis machine and patient related factors. Drug factors: low molecular weight compounds more likely to get filtered, more hydrophilic drugs more likely to get filtered along with the water, plasma protein bound drugs less likely to cross membranes, high volume of distribution more distributed in the tissues, less likely to be excreted in dialysis, the type of the dialysis filter, how much it can absorb drugs, that can affect drug clearance, the surface area, larger the surface area, more is the clearance, blood flow and dialysate flow rate, whether the dialysis filter is reused, whether the patient has liver disease, and the total fat content or body weight. All of these can affect the clearance of the drugs in hemodialysis. So certain examples where the clearance of the drugs has been measured on conventional, that is low flux or low flow, and high flow dialysis, naturally with the high flow dialysis, the clearance of most of the drugs is found to increase. More so with vancomycin especially, the type of filter that we are using has a significant impact, where whether we use a polysulfone filter or a PMMA filter, the clearance is likely to change. There is something called as augmented renal clearance which can occur in early stage of sepsis. This is a compensatory mechanism where the body tries to increase the cardiac output, and this can increase the renal blood flow and transient increase in the renal clearance of drugs. So this was one study which showed that the clearance of beta-lactams and aminoglycosides in the initial stages of sepsis may be enhanced, so the doses initially may have to be higher. So we may have to start with higher doses of these drugs while starting therapy. Mechanical ventilation can reduce the cardiac output. Mechanical ventilation is a state of artificial respiration where the intrathoracic pressure is made more negative. The cardiac output can reduce, which can reduce the blood flow to various organs, and this can affect the drug clearance. As an example, the clearance of vancomycin was found to be reduced by almost 1/5 in patients who are on mechanical ventilation. Extracorporeal membrane oxygenation, the membrane, tubings that we use can sequester the lipophilic drugs. So drug adherence or drug retention on these tubings can actually lead to loss of drug in the body. Drug-drug interactions can occur if there are multiple concomitant medications are administered, and study has shown that if the number of drugs increases to 10 concomitantly, then the risk of drug interaction increases 8-fold. And needless to say, this is a population where up to 7 or 10 drugs is found extremely common. So just to state a few examples, cefuroxime population pharmacokinetics has been studied in the critically ill, where 160 samples were obtained from 20 patients. The probability of attaining the pharmacodynamic target, which is a 65% of the time above MIC to be achieved for the free drug, considering a MIC of 8 mg per liter. This study evaluated multiple doses of cefuroxime. There was an intermittent dose given as a half an hour bolus, and then there were extended infusions for up to half of the dosing interval. One was every 8 hours and every 6 hours, and then there were continuous infusions for 24 hours. So this study showed that with a high renal clearance or with a normal renal clearance, as the continuous infusion is given, the probability of attaining the PD target is high. As we go for intermittent infusions, as we go for lower doses, the probability of target attainment actually reduces. And of course, with a reduction in renal clearance, the clearance of the drug itself is reduced, and there is likely to be an accumulation of the drug in the body. So this study concluded that intermittent bolus is not likely to achieve the therapeutic target. So for a drug like cefuroxime, continuous infusion at higher doses is a better alternative. Similarly, another example for vancomycin, a multi-center study was done on 42 patients from 26 ICUs, out of which 57% received vancomycin as a continuous infusion and the remaining achieved as an intermittent bolus. The attainment of semen and AUC 0 to 24 hours was evaluated in this population. It was seen that overall semen was attained in only up to 57% of cases and AUC in up to 71% of cases. More so, it was more likely to attain the target, both semen and AUC, with a continuous infusion than with the intermittent bolus. So, large variation was observed in the pharmacokinetics of vancomycin in this population, and they said that the current dosing regimens are insufficient to attain the target PD levels. A similar study was done in our own center by one of the previous PhD students, where the steady state vancomycin levels were evaluated in both pediatric and adults intensive care units. It was found that up to 66% of the pediatric samples and up to more than 70% of the adult samples were less than 10 microgram per ml, which is below the therapeutic range. So basically we are underdosing our population. The reason could be fear of toxicity, but the risk is clearly there, a lack of therapeutic effect, which may further fester drug resistance and ineffective treatment. So this is a paper published in 2020, which I would recommend you to read, a revised consensus guideline given by multiple societies who have come together and who have given dosing recommendations for vancomycin. So timing when to start antimicrobial therapy in the ICU, there are various guidelines that have been given, but the simple dictum is earlier the better. So the black bars here show there are multiple studies which have evaluated delay in the initiation of antimicrobial therapy as shown in the black bar, and the white bars show early or timely initiation of antimicrobial therapy. The difference in the mortality rate is glaringly obvious. So earlier the better. Certain recommendations mentioned in the literature, goal-directed pharmacotherapy. So when you start treatment in this critically ill population, you have a goal. You decide what is the PD target, what is the PK target that you want to attain. And previously what we were saying, one dose fits all is no more true. Rather, a better option is go for individualized treatment. How do we do that? There are PK/PD based decisions or algorithms which are available, and this is where we as clinical pharmacologists come in. A wonderful example was given yesterday by Dr. Sumit Mathew when he discussed the same thing. Best Dose is one of the softwares that they are using in JIPMER. There is another live software which is available. So there are softwares available which help you to decide on what is the optimal dose based on the PK/PD characteristics of that particular drug and even the patient and the disease characteristics. And as clinical pharmacologists, we always recommend TDM, at least for drugs like vancomycin, aminoglycosides and voriconazole. These are the drugs where there is absolutely no doubt that TDM will definitely improve the outcomes. And as it is always said in any literature, any paper, existing literature is insufficient. Further studies are needed to get more information. Furthermore, suggestions which have not been definitively proven but yes can be tried. We may need local guidelines in ICU settings. So each, as we know, the pathogen pattern will be different in different ICUs. So we may actually need ICU tailored guidelines for antibiotic use. So considering the local antibiograms, considering the local resistance pattern, the local guidelines may have to be framed. Can rapid diagnostic methods be used? Maybe. Rapid diagnostic kits which are available as point of care service may help in deciding whether to start antimicrobial or no in a particular scenario. Can we use artificial intelligence machine learning? Maybe. Can be tried to develop the dosing algorithms. So to summarize my presentation, there are pathophysiological changes that occur in the critically ill population. There are organ support therapies like mechanical ventilation, ECMO. All of them can affect drug PK/PD. A knowledge and understanding of this is important for a clinical pharmacologist for devising a proper dosing regimen for safe and effective pharmacotherapy in this population. The dose optimization and optimal timing of initiating the therapy, these are important predictors of outcomes including mortality. And goal-directed therapy, which can be based on PK/PD models, and therapeutic drug monitoring can be used for individualizing therapy in this population. So with this, I conclude my presentation and on time, exactly. So, thank you for listening, and if there are any questions, I'll be happy to answer them.
Morning, sir. Just take the question at the end, so that all the
Okay, no problem. Okay, thank you.
So thank you so much, Dr. Krishnamurthy, for your excellent speech, which I am sure will benefit all of us. Okay. So now our next speaker. So I would now request Dr. Maulik Doshi to kindly deliver his speech entitled Interpreting Antibiogram. So, Dr. Maulik, please.
Online? He's online. The boro boro.
He is in online.
Yeah, hello, good morning. Am I audible?
Yes, yes. Okay.
All right.
Dr. Maulik,
Yes.
Okay.
Thank you very much, madam. So, I'm just sharing my screen. Is my screen visible? Is my screen visible? Can you confirm?
Yes, yes.
Yeah, thank you very much. So, it's really great to be here. Unfortunately, I cannot attend the conference in person because of some personal commitment. So, now if you look at nosocomial infection in ICU, it is around 11 to 60% in India. Now, when we look at the economic burden of this nosocomial infection, so in ICU settle, so it is around 1,80,469. So it is coming very costly. And antimicrobial resistance, we can see it is rapidly rising, which Dr. Bhaskar already mentioned. Now, when we look at what are the reasons for this infection and how we can reduce it and how we can reduce the economic burden, so there are multiple factors which plays into this infection and the antimicrobial resistance. One of the solutions can be a judicial use of antibiotics. And for that judicial use of antibiotics, the important part is that the antibiogram program. So if you look at the government initiative, Government of India is also taking so many measures to address the antimicrobial resistance. Even if you look at the state-wise initiative, then Kerala becomes the first state to release an antibiogram. So nowadays, antibiogram profile, it is coming very needed, and all the states are anyway eventually following this solution, and this will be really helpful in curtailing the antibiotic resistance. So with that objective, that solution, I would like to congratulate the organizer of ACPICON2023 who have taken this session, and this is my disclaimer, standard disclaimer. This is in the outline of the presentation. So first of all, we'll discuss on the introduction of this antibiogram, then what is an antibiogram, then components of an antibiogram, then which are the factors which affect the interpretation of an antibiogram, and how to read an antibiogram, and then future trends and the technologies. Now before going to the antibiogram, the key question is, what is the current knowledge, attitude and practice regarding the antibiotic use? Now let's look at from different part of India. So let's look at from publications from South India. So this paper, it discusses about knowledge, attitude and practice related to the antibiotic use and resistance among the public of coastal South Karnataka. And what this paper says that the knowledge regarding antibiotic resistance and its causes is limited. The focus in the future should be on creating awareness among the public on the prevent use of antibiotic. Another paper from AIMS Chairpersons, Rajasthan, it says that the knowledge level of medical student was quite satisfactory. However, the attitude and practice which are concerned, there is a need for substantial improvement. Somewhere here it talks about the antimicrobial chemotherapy and its usage. So here there is a role of a clinical pharmacologist. That in the curriculum only, that should be a knowledge given to use of antimicrobial therapy. So now coming to the antibiogram. So it says, now the M39, which is a guideline published by CLSR, it says the report which is generated by analysis of result on isolated from particular institution in a different part of time, which reflects the percentage of first isolate, which is per patient. Pathogenous species that is susceptible to each of the antimicrobial agents routinely tested. Now, what are the components of antibiogram? So, broadly we can categorize the components of antibiogram into four: bacterial isolates, an antibiotic, and the susceptibility. So, these three are the core components in any antibiogram from any institute. Some of the institutes in India as well as globally, they also give minimum immediate concentration. Sometimes they also give the clinical interpretation with the help of clinical pharmacologists. And they also give the epidemiological information about the resistance pattern in the particular region. So these are the four broad components of the antibiogram. Now, what is the purpose of antibiogram? It will actually facilitate the tailored antibiotic therapy for individual patient. So many times when we have to do empirical therapy, we should be knowing that which antibiotic should be given. It helps in that. And it is by selection and selecting the effective antibiotics, mainly for the empirical use. It assists in curbing the antibiotic resistance by optimizing the antibiotic use. What are the key benefits? Healthcare provider, it can choose antibiotics which are more likely to be effective in treating the infection. And it will also minimize the risk. These are the bacterial isolates. So these are the bacterial isolates. These patients are looking in culture. Now when we look at the results here, it can categorize into susceptible, intermediate, or resistant. So susceptible means it shows antibiotics are beta-lactam, cyclosporin, and other. So these are the key components of the antibiogram in any institute. Now, many times, as I said earlier, that antibiogram also gives the level of minimum immunity concentration. So now let's understand what is the important part. So this is a case study. So there is a strain of Escherichia coli which has an MIC of 2 microgram for amoxicillin and MIC of 8 microgram for cyclohexane. So which antibiotic to be selected? So here it is showing the in vitro efficacy of amoxicillin chlorinic acid. So this types of sensitiveness in the MIC, intermediate and the resistance. So this resistance is a breakout part. So this is tested in various concentration of amoxicillin, and this concentration, that is 2 microgram per ml, it shows the more sensitive MIC. Now another part. So this shows it should be more sensitive. Whenever it is a this information it is very helpful from the antibiogram from any institute. Now there are various factors which affects the interpretation of antibiogram. So once we have the information about the susceptibility, then we come to the analysis. The susceptibility, then the analysis. So one of the parameters is the age of the patient, then the underlying health condition. It's energy and immune status. The patient will be susceptible to the that should be also considered. Then the severity of infection and its potential complication. So if the infection is more severe, then it may require sometimes the highly potent antibiotic. So with that, for that patient, the NIC really will be helpful. Take the site of infection. In both sides, they will have unique bacterial flora and the resistance pattern. The antibiotic penetration and efficacy can vary on the infection location. So Dr. Bhaskar just mentioned earlier that there can be some antibiotics which are very much soluble in the lipids, so it can cross that barrier and reach to the penetration site. So that is why we should be knowing that at which side, whether it is skin, whether it is intestine, where the antibiotic, whether infection is there, and based on the type of infection and antibiotics, often we should select the antibiotic. Then the PK period antibiotic. So this Dr. Bhaskar already mentioned that the absorption, distribution, metabolism, negotiation, it actually affects the effectiveness of antibiotic. And the PK period, it helps in optimizing the dosing for maximum bacterial cleaning. Local resistance. There are some regional variation in bacterial resistance profiles which can option. Then co-infection Antibiogram, it may not follow the co-infection part. So co-infection, if it is there, then there will be multiple bacterial species which are complicated interpretation. So here, this is also when clinician is antibiotic, we should be with the correct antibiotics. Now, how to read an antibiogram? So first step in antibiogram therapy is that we should identify the bacterial species. So it's a research product. Then we should select the antibiotic. Now, antibiotic, there can be various MICs, various susceptibility. So we should select the highly potent antibiotic, and that is based on the MIC and the susceptibility pattern. Then local susceptibility or the susceptible resistance. Then consider the scenario. So given scenario as we discussed earlier, PKPD that should be also considered, age of the patient, immunity status, all these factors should be considered, and then
Sorry, Dr. Doshi, we cannot hear you. And your slides are also not visible. There is some network issue, I think, from your side. Sometimes there is network interruptions are there. So please unmute yourself. Team Clarinet, can you hear us?
First, Dr. Doshi to unmute himself.
Yes, now you are audible. I think there is issues in your network connection. So, can you please sum up, because as we are running short of time also. So,
And the
slides are also not visible. Yes, now visible.
Visible, right?
Yeah.
Okay. So, now when we look at the future trends and technologies of antibiogram, so much is on the plate. The first one is the genomic based approach. So utilizing the whole genome sequence to identify the resistance genes. And as a pharmacologist, with the pharmacogenomic technique that can helpful in understanding of the diagram. Then there is a rapid diagnostic method. Then PKPD modeling, machine learning and AI. So this is a new buzzword across everywhere. Machine learning and AI. So antibiogram is also part of this machine learning and AI. So predictive models are going to prepare. So what happens in this model is that whenever any hospital prepares antibiograms, it is having so much of data. Now, whenever any patient is using a antibiogram, and if it works, then they share this data to the lab which prepares antibiogram. And based on that data, and the lab will predict that in the future when they are preparing antibiogram, what kind of updation can be there in the antibiogram. Then precision learning in infectious disease, microbiome analysis. So here there is a role of patient's microbiome composition, impact of microbial communities on infection and the treatment response. So another approach
Maulik, we can't hear you. I think maybe you can switch off your camera, maybe that might increase your bandwidth.
I think there is some issues with Dr. Doshi's net connection. We'll surely connect him. But I think I request Madam to proceed for the next session, as we will be delayed.
So, thank you, Dr. Maulik, for a great presentation. So, now our next speaker, I would now request Dr. Professor Dhaneria, S.K. Dhaneria, to present his speech entitled Rational Use of Antibiotics. Please.
Can I start? Should I start? It's connected. Honorable Chairperson, my esteemed colleagues and distinguished delegates, at the outset I express sincere gratitude to the organizers for giving me this opportunity to interact with you. Slide. In this deliberation, I will be sharing with you the topic need to rationalize the use of antibiotic and few points about the antimicrobial stewardship. There is a significant burden of infectious disease in our country, and our country is the largest consumer of antimicrobial drugs globally. Antibiotics are often overused in clinical practice. Antibiotics are one of the most commonly prescribed drugs, being responsible for 30 to 50% of hospitals' total drug budget. Antimicrobial resistance is a well-recognized global threat to the human health. Antimicrobial resistance is closely linked to overuse and misuse of antibiotics. What are the situations where we are overusing and misusing the antibiotics? Use of antibiotic in every case of fever. This is highly unjustified because there are a number of non-infectious causes of fever also. Use of antibiotic for untreatable infection means using the antibacterial drug for the management of viral illness. When actually surgical intervention is required, we are depending on the frequent use of antibiotics. If there is an abscess, it is to be drained. If there is foreign body, it is to be removed. If there is renal stone causing recurrent UTI, the surgical intervention is required, not to repeatedly use antibiotic to treat the recurrent UTI. Unnecessary use of systemic antibacterial. If there is a superficial infection, cleaning of the wound and local antiseptics will be sufficient. There is no need to use the systemic antibacterial. Over-reliance on the parenteral antibiotic. Parenteral antibiotics are indicated when patient is critically ill. Our nature of antibiotic is such that we cannot use it orally. Our patient condition is such that orally drug cannot be used. Because unnecessary use of parenteral antibiotic will increase cost of therapy, prolong hospital stay, and also increase the risk of IV line infection. Many times antibiotics are used in very high dose in order to obtain a quick and intense effect, but at the cost of toxicity. Another scenario where antibiotic is used in low doses because of the apprehension of adverse effect, and this may lead to therapeutic failure and also increase the risk of emergence of resistant organism. Discontinuing the antibiotic just on the basis of clinical improvement without ensuring the cure may lead to therapeutic failure and also increase the risk of drug resistance. Sometimes the antibiotic is prescribed because of the patient. The physician may succumb to the pressure of patient to prescribe the antibiotic and that too the injectable. Sometimes it is the irrational drug promotion by the industry which lead to overuse and misuse of antibiotics. Sometimes the microbiological information regarding the infection is not available, and because of that, the physician uses number of antibiotics to cover all the offending microorganisms. Antibiotics used for prophylaxis are often inappropriately chosen and administered. 30% of antibiotics used in hospitals are for prophylaxis, and more than 80% are given inappropriately for more than 48 hours duration. For prevention of surgical site infections, there are very clear indications when to be used. For clean contaminated surgery, contaminated wound, dirty wound, surgeries involving prosthetic material, heart surgery, neurosurgery, because there the occurrence of infection will be drastic, will have drastic complications, and immunocompromised patient. Cefazolin is universally accepted drug for prevention of surgical site infection to be used in the dose of 2 gram intravenously within 1 hour prior to incision. Mostly we require single dose. An alternative to cefazolin, if it is not available, is the cefuroxime. But in clinical practice, we are using many antibiotics for prevention of surgical site infection and also for a longer duration. Antibiotic prescribing with misconceptions. Newer drugs are always the better drugs. Costly drugs are always the better drugs. Branded drugs are always the better than generic. So these are the misconceptions. Expensive drugs are more efficacious. That is wrong notion. Not always true. For prevention of surgical site infection, cefazolin is recommended, and third generation cephalosporins, which are expensive drugs, are offering no advantage over the cefazolin. New antibiotic is not the answer to every infection, The fifth generation cephalosporins, ceftabiprole and ceftaroline, have limited activity against the anaerobes. Tigecycline is not effective against the Pseudomonas. Polypharmacy is always better. It's a misconcept. Polypharmacy is indicated when the patient is critically ill, life-threatening infections, chronic diseases like tuberculosis, leprosy, or polymicrobial infection. Unnecessary use of too many antibiotics will increase cost of therapy. There is a risk of adverse drug reactions, also drug interaction, and also there is a risk of emergence of resistant organism. Fixed dose combinations are always better. That is again misconcept. Our market is flooded with too many FDCs, but if you go to the essential medicine list of our country published in 2022 and of WHO 2023, these are the antibiotic FDCs are enlisted in list: sulfamethoxazole trimethoprim, amoxicillin clavulanic acid, piperacillin tazobactam, ceftazidime avibactam, meropenem vaporbactam. And the last one is added in the WHO Essential Medicine List 2023, the ceftazidime with the tazobactam for Pseudomonas. Now, about the antimicrobial stewardship. As per the Centers for Disease Control and Prevention, what is antimicrobial stewardship? It is the use of right antibiotic for the right patient at the right time with right dose, right route and correct frequency, causing least harm to the patient and the future patient. WHO has also defined antimicrobial stewardship, and Infectious Disease Society of America has also defined the antimicrobial stewardship, emphasized on the responsible use of antibiotic. Antibiotic should be correctly chosen, its dose should be appropriate, and it should be given for adequate length of time. So what is the goal of antimicrobial stewardship? Optimizing the antimicrobial selection, dosing, route of administration, duration of therapy to maximize clinical cure or prevention of infection. That is first. Second, limiting the unintended consequences like emergence of resistance, cost of therapy, adverse drug event, and promoting rational and judicious use of antibiotic, and also prolonging the lifespan of existing antimicrobial. So these are the goals of antimicrobial stewardship. Antimicrobial stewardship team is consisting of infectious disease physician, infection control officer, clinical microbiologist, internal medicine physician, clinical pharmacist with infectious disease training, antimicrobial stewardship nurse with infectious disease training, officer in charge of pharmacy, and now included clinical pharmacologist. So it is the team, antimicrobial stewardship team. This antimicrobial stewardship team is led by antimicrobial steward, who may be the infectious disease physician or infection control officer or clinical microbiologist. In large hospital, we can have more than one antimicrobial steward. So what are included in the antimicrobial stewardship program? We have to frame an antimicrobial policy in the form of handbook, easy to carry. Depending on the common infectious disease, we follow the syndromic approach, and from valuable inputs from the microbiology department, we prepare the antibiotic policy. Implement the AMS strategies front-hand and strategies and back-end strategies, and also educate not only the healthcare professionals but also the society for the rational use of antibiotic. What is the front-end strategy? Formulary restriction and pre-authorization. So we divide the drug, non-restricted agents like access group. The agent for which the pharmacy supply does not require AMS team approval. It includes the first and second line drugs for common infectious disease. Semi-restricted agents, watch group, agents for which the pharmacy supply of more than 48 hours require AMS team approval. These are the drugs where the risk of resistance is more. And in restricted agent, these are the last resort agent for multi-drug resistant infection. And for their supply or prescription, the AMS team approval is required. If physician wants to prescribe the drug from watch group for more than 48 hours or want to use the drug from restricted group, he has to fill the form, pre-authorization form, and the AMS team will give the decision on approval or denial within the time. According to the WHO aware tool that recommends that 60% of all prescribed antibiotic must belong to the access group by 2023, means we should restrict the use of watch group and restricted group of antibiotic. What is the back-end strategy? It is done by discussion between the AMS team and clinical team on antibiotic prescribing practices. Advice is given on empirical, targeted, and prophylactic therapy. So here we can go for escalation. Suppose the organisms are sensitive to ceftriaxone, piperacillin, tazobactam, and meropenem. Then if we were using piperacillin, tazobactam, and it is, say, sensitive to the ceftriaxone, we go for the step-down approach, means de-escalation. Means from watch group we will go to the access group. Suppose the organism is resistant to first and second line drug including the piperacillin, tazobactam, and sensitive to meropenem. We stop the piperacillin, tazobactam, and we can use the high line antibiotic like meropenem. So it will include narrowing of spectrum, removal of the overlapping spectrum, means meropenem and piperacillin, tazobactam, their spectrum is overlapping, so no need to use both. No need to add metronidazole to meropenem when there is mixed gram-negative bacillary and anaerobic infection. Meropenem will take care of anaerobes also. Once the patient is febrile, clinically stable, culture is negative, blood counts are normal, procalcitonin level has come down, we should stop the antibiotic. And we can switch from IV to oral. If organisms are sensitive to, say, nitrofurantoin and ciprofloxacin, in place of using the IV ciprofloxacin, we can use to nitrofurantoin orally. Then the change of antibiotic within line and across the line. Within line means we are changing between the access group or watch group or restricted. And across the line means we are changing from restricted to watch or watch to restricted. So there are a number of actions which are taken. Suppose there is allergy to beta-lactam, we should not use ceftriaxone. In children, we should not use tetracycline and avoid use of fluoroquinolone. If it's a meningitis, better to go for meropenem rather than using imipenem and cytostatin. In 1945, Alexander Fleming, in his Nobel oration, warned the world of danger of over-reliance on antibiotic and the threat of bacterial resistance. Paul Ehrlich mentioned about the problem of drug resistance. Drug resistance follows the drug like a faithful shadow. These words of father of the nation, are true word by word as far as the antibiotic prescribing practices are concerned. Your beliefs become your thoughts become your words become your actions become your habit, and your habits become your values. When an organization is developing antibiotic, they usually feel that their investments goes waste, because antibiotic is to be used for short duration, it cures the disease, and in due course of time there is a possibility that this antibiotic may become ineffective because of the development of resistance. So we have only few antibiotics in pipeline. There is a limited resources of antibiotics, so antibiotics are very precious drugs. These are to be preserved, and there is a need to rationalize the use of antibiotics in interest of science and society. If we use antibiotics when not needed, we may have them we may not have them when they are most needed. Antibiotics have saved our life for so long. Now it is the time for us to save the antibiotics. Otherwise, we will end up in situation, bed bugs, no drugs. So this crisis of antibiotic resistance may revert the civilization back to the pre-antibiotic era. So I conclude my presentation with the words of great Greek physician Herophilus. Medicines are nothing in themselves if not properly used, but the very hands of gods if employed with reason and prudence. Thank you very much for kind attention. These are my references. Thank you very much.
Thank you, sir, for excellently illuminating speech. So now any question, any doubt can ask.
I appreciate the lecture Dr. Bhaskar told in the morning, first lecture.
Hello.
Hello. Yeah. Precisely, it's okay what we discuss in meeting, in lectures and other thing, and what I listened yesterday also, Dr. Soibal's discussion. We need to do practical works more, what we teach, PKPD, etc. It's essential to get the knowledge implemented in the clinics, and that is lacking. And that to be done to get the knowledge earned by the clinical pharmacologist. Dr. Huda is here, we were in the same talk in the Patna meeting also. That's why we started this group who should not be only theoretical clinical pharmacologist, in practical sense also, to get benefit of knowledge of clinical pharmacology to the patients. And for that we have to work extra mile. Because sometimes we teach, take the exam, declare the results, means mainly all theoretical part as a teacher. And for that we are paid. But to make a mark, to do something extra, you have to work extra. Like clinical microbiologists, they are part and parcel of a hospital because they give culture sensitive report, and then the clinician, of course they start empirical therapy first, but then finally they give honor to CS. But there we are lacking. We discussed TDM, but very hardly, few places is there a TDM lab, like in PGI I think, in JIPMAR. And sometimes it is said that lab is not there, government is not support, because of our lack of interest is also important. Like a microbiology, next generation sequencing lab in Croats, they are being given by the authority, because I am an academician as well as now as a administrators, I feel, where is the lacking? Lacking is there is lack of interest of ourselves, I am telling it. Unless we showed interest to the authority, they will not give the support. But still, it's a good sign that is happening now. In our school, college time, when I was a student, that time it was exclusively only for teaching and learning in pharmacology. But now, many of us are joining in industry, means in the hospitals also like this, and giving some help. And finally, I tell that this town is the first pharmacologist. Colonel R.M. Chopra was here. I think in the history we call him father of pharmacology. 17th August was his birthday, 1882. And he worked in School of Tropical Medicine, the historical place. I visited many times there when Dr. Tripathi was there. And he started DM Clinical Pharmacology also here. And they have started the outdoor in clinical pharmacology. So that's the gist, and that is the starting. And now in the history we also can quote, Dr. Dhaneria has quoted so many things. Gokhale told once that what Bengal thinks today, India thinks tomorrow. So Dr. Tripathi and this young boy have a great expectation, Samajdar. They have started good beginning here, and that should be circulated and spread all over the India. Then only we should consider that we are part and parcel of the hospital. Clinical pharmacology students should be posted like the clinical microbiologist residents. They do journal graphs, they do the topics, lectures, etc. But simultaneously they are posting in lab. Clinical pharmacology lab should be there. Residents should be posted there regularly. Samples should come there to get the TDM or to get the only we are restricted now ADL and other things, drug utilization, some studies are there. But that is due to compulsion of sending the reports to Uppsala and other thing. So with these few words, I congratulate this effort. About Dr. Dhaneria, your other quotes I appreciate, but about Father of Nation, as much as I am reading, he is telling something this year and next year he is changing his mind, thought and other thing. So I have some reservation of about his quote. Thank you.
Thank you, sir. Just to extend, do I have the permission to say what Smita madam had taught me during my DM days? There are two areas where a pharmacologist can actually dictate a clinician: pharmacokinetics and biostatistics. If these two topics are strong, you can actually tell a clinician what to do and how to do. Thank you.
Now may I request Professor Nihar Vishwas sir to please felicitate Professor Chayna Sarkar. Sir,
Ready?
Now also may I request Nihar Vishwas sir to please felicitate Professor S.P. Dhaneria sir.
Your colleague from PGI Chandigarh.
Bhaskar.
Very good. Chalo. Name also. Acting sir. Great.
Sir. Once more. Thank you.
Also, Dr. Bhaskar, please come.
Bhaskar is our student from AIMS. And PGI also, no? MD, MS and DLPGI.
Once more.
He has written a book, you have given uncopied.
Yes. Thank you, sir.
Thank you, sir. So, for the next session,